I have no disclosures. That's my daughter, Lavinia, who just turned 5 months old. She's barely in 3-month-old clothes, so she's just a little peanut. My son was in 3-month clothes when he was like 2 weeks old, so it's very weird having a small baby. We're not used to it in my family. So I run the dual diagnosis unit these days. I'm also the president of the West Virginia Society of Addiction Medicine, so I'm sure some of you are probably members of it. But that can be helpful for advocacy and things like that if anybody wants to reach out to me ever about things. So really the objectives of this talk, keep it pretty straightforward. Mitra, you shouldn't have given me 45 minutes. This is a problem. I'll go long. So really looking to the various treatment options for opioid use, just kind of in general, which we all know about, but then talk about, again, the specific settings that you can use MAT. So how we can initiate it in the outpatient setting, which we should all be fairly familiar with, but also inpatient, and actually how you do it in the emergency department. And then just kind of look at the plans of care. How do we approach it for kind of, we're not going to go into like a full case, but kind of theoretic cases. Again, I thought I only had about 20 minutes, otherwise it would make it longer. But we all know MAT, it's a gold standard of treatment for opioid use disorder. So for those who read the Surgeon General's report, I think it was this year, maybe it was last year, but he specifically says that MAT is the gold standard. As we all know, every professional society recommends using medications. There are 3 medicines that are approved. They all are considered first-line treatment for OUD. Of course, we don't think very much about methadone, at least in this setting, but methadone is still there, and it's been there for decades. Methadone has kept a lot of people alive, and it really has helped a lot of people since the mid-1970s. Naltrexone, we don't use it as much in this setting, of course, but naltrexone, a lot of people do fairly well with naltrexone. It's hard to get them on it. It can be hard to keep people on it, but there are some people that do very, very well with naltrexone Vivitrol. And then, of course, buprenorphine, which is mainly what we discuss here. As always, we talk about the goals of treatment, decrease morbidity and mortality, and increase the quality of life of those that are affected by this terrible disease of opioid addiction. All right, so in the outpatient setting, a setting that most of us are pretty familiar with at this point. But for someone who's seeking care, so just kind of the ordinary, run-of-the-mill person who struggled with opioids, say they were in a car wreck years ago and they got stuck on opioids for way too long and they developed a pretty serious addiction to them. So somebody who's coming into our office, the normal person we see, so the options are in general. So in the past, it's still an option, is we can refer them to a daily methadone clinic or OTP. So this is clearly still an option for us. There are certain circumstances where someone would probably need that level of care and it can be beneficial. So that is one option for folks, historically and still presently. It's high intensity, right? High cost. You better live close to one because you're going to be there every day at first. You could put somebody on a detox unit. This is what we historically would do for folks that wanted opioid treatment, is we detox them. We wait 7 to 10 days and we put them on naltrexone if they stand the detox. I've done this for hundreds of people. My old job, I used to moonlight at a detox unit, Valley Crisis Unit. So I've detoxed a lot of people and put them on naltrexone. Some of them have done very well with it. Well, as we all know, it's difficult to initiate the medicine. People leave, but it can work again. So, one size does not fit all, clearly, in opioid addiction. And I think sometimes, too, if we get in the habit of pushing one side too much, like saying it always has to be Suboxone, nothing else, or it always has to be methadone, or whatever it is, that really is off-putting for people, I think. It is better to have options and let people know, especially kind of in judiciaries and law enforcement. Let them know that there are different options, but the goal is always medicine. The particular medicine, not as important as the goal of getting them on medication, keeping them alive, but move on. And then, of course, what we typically do and what we try to teach everybody here is, but start them on buprenorphine, naloxone, ideally to combine with the other outpatient modalities that we try to offer through CODE and through your programs. So this is definitely effective and it's safe to do. And it is pretty simple for those who know to do it, how to do it correctly. Historically, for when you teach people how to use BUP, it's kind of funny. It's like you're teaching them some kind of magic or something, but it's really not that complicated once you've done it a handful of times. So it's a lot less mysterious once you get used to it. So how do we do good treatment? And we all know this, but you try to do frequent visits, so seeing them often, give them only enough medicine to get from visit to visit, at least at first, right? No month supply initially. You know, one of the things we've been talking about is Sublocade. And if anybody separately wants to message me, it would be great. But we're working on trying to get Sublocade here at Chestnut Ridge and at Ruby in general. And we've had a lot of issues with it. Going forward with the other forms of injectable BUP, that should make a life a little easier. But it's kind of interesting because Sublocade doesn't have a lot of great patient retention. And I think part of that is because you get a 1 month supply and you kind of disappear, very similar to Vivitrol. But frequent visits, responsible dosing, you know, we're typically aiming for 8 to 16 milligrams, sometimes lower, possibly higher. So we're about to do a study where we go up to 32 milligrams. I'm very curious to see how that goes with people, but that's really a target dose. And certain places, certain countries, they routinely have people on 32 milligrams. I know that's something we've talked about a little bit here, but stay tuned on that, put it that way. We obviously try to avoid monotherapy product of BUP, so no Subutex. We do the UDSs, we do the pill and film counts. We require abstinence from other substances. It can be tricky, of course, especially with meth and marijuana as it becomes increasingly legalized, quote unquote, for medicinal purposes. We have the therapy component. We try to engage peer recovery if we can, responsible peer recovery that's supportive of them being on medicine. And of course, always open communication between patient and all their providers. So what's the philosophy of good MAT? Again, containment of the disease of addiction, not a cure. You know, the idea of fully curing an addiction it's nice to think about, but you know, whether it's possible or not is another question. So we can contain it. We can't necessarily cure it. It is a collaboration with the patient. Again, you know, finding what they want to do, what they want out of it, and trying to work with their goals. There are no miracles in a pill or a film for that matter. It's multiphasic, so typically there's kind of a detox / stabilization, and then, you know, on to more like a recovery scenario. We use lots of different people. So we have the prescribers, we have therapists, we have peer recovery coaches, law enforcement, care managers, all those people, we all play a role. Multidimensional, again, if you look at this addiction as a disease, but it's a multidimensional disease. So we try to intervene in all the different ways that it affects people's lives. So bio, psycho, social, and even spiritual aspects of it. When you look at that biological, of course, you know, we focus on the MAT, but the other medical things that are going on. So people will get sober and then suddenly they realize, oh my gosh, I do have hypertension and I've got Hep C that needs treated, but I've been ignoring because I've been in active addiction. So we try to treat the other disorders, medical disorders, but also mental health disorders. Definitely something that kind of comes to light. Psychologically, you know, MI, of course, motivational interviewing or enhancement therapy can certainly help. CBT, acceptance and commitment therapy can be helpful. From a social side, again, the peer recovery coaches can be so instrumental in getting people well, can also sometimes sabotage it if they're completely against MAT. So I just, you know, always tell people, ask your clients what they're hearing or what their peer recovery coach, if they have one, are they accepting of them being in treatment or not? Because that has definitely been known to sabotage people. 12-step meetings, again, kind of mixed bag, but more good than bad, hopefully. Family therapy, vocational training and rehabilitation, you know, very important. If somebody's been using for years and their main source of income is stealing or selling or things like that, sometimes they might not have a vocation beyond dealing. So trying to get them back into to a place where they can work again. Of course, stable housing, such a big thing that I think we'd all agree on, is it's very hard to be sober if you're living in a homeless shelter or on the streets. You have no supports. Stable housing is so key to people's recovery and doing better in time. Then, of course, from a spiritual aspect, getting them back in their faith community. So it's, when you're actively using, a lot of these people are, they separate themselves. There's a lot of shame in it, right? So they're not going to church, or they're not going to their synagogue, their temple. It's very difficult for folks. So getting them back into the faith community that they've kind of shunned for years or felt shunned by can be very helpful for folks. And again, trying to replace these years of guilt with some newfound hope. Things can get better with the right interventions. Okay. So basic kind of plan of care that you can look at it. Again, this is not rocket science, but it's just a good way to kind of conceptualize this, I would say. So you get them started on an appropriate dose of MAT, you pick. So the goal, no withdrawals or cravings. Typically they say don't exceed 8 milligrams total of BUP when the first day that you're dosing someone. And they do find that home induction is as effective as the office-based induction. So I'm sure most of you probably give them medicine, they take it home, and they see how they do with it. And the way I talk to people about, how much is enough or what are we aiming for is just you get on the medicine and you look and feel normal. So, you don't look like you're using. You don't look bad because you're withdrawing, you just look normal. So I can't pick you out of a lineup because you just look and you feel normal. That's my goal, and that's what I tell people I'm looking for. So we're arranging those weekly meetings initially, and then we do work to make them less frequent with more sobriety. So as a reward in part. So you're doing well, so you don't need to see me every week or every other week. So abstinence from other substances is expected, especially sedatives, right? Because that's where Suboxone, buprenorphine becomes dangerous, is when we mix it. I say abstinence from smoking is encouraged. We often ignore the fact, but the reality is that 480,000 people die every year in the US of tobacco-related illness. Overdoses is a little north of 70,000, although probably this year with COVID, it's possible we might hit 100,000 this year. Opioids individually were about 50,000 deaths. So you look at that, 480,000 people a year die of smoking. So definitely trying to get people off tobacco. And the reality is if you're able to do that, they're less likely to relapse on opioids. So that's great. Of course, we're doing the random drug screens and pill and film counts to ensure accountability. And again, peer recovery work with meetings and individuals if we can. And again, over time, we evaluate our treatment plans and we decide, is this going well? Should they stay on the medicine? Is the dose correct? Or do we need to change tactics? Do they need to go to a residential program? Do they need to maybe go on methadone? Maybe even naltrexone. So, being flexible with it can be very helpful. All right. So in the inpatient setting, so we're going from outpatient to inpatient. How do we do it? So the examples I use, because we've dealt with it a lot at Ruby, is the acute endocarditis patient. So someone who's pretty sick could die, will die if they don't get surgical treatment. So someone who's deathly ill, they need surgery, they've been using opioids, they've been injecting opioids, that's how they got the endocarditis. So how do we approach this type of patient? So in the past, a lot of people, and still sometimes today, people argue no surgery to allow endocarditis patients to die. It's unfortunate, but it does happen, and especially when you've had folks that have had 1 or 2 valve replacements already. It's terrible when you send a 25-year-old home on hospice because surgery won't go back in and clean out their heart, but it happens. So that's historically what would happen. From an ethical physician's perspective, argue this isn't really an option. The surgical societies will say the same thing too. Now, whether individual surgeons agree with that, that's what it really comes down to. We can't force someone to do surgery on anyone. So an option is you could place someone on MAT immediately. Again, this is somebody that's acutely sick and a lot of pain, needs surgery. that's an option. But keep in mind that with bup by itself, it can be difficult to control severe pain with bup. And methadone, if you're using it inpatient, it can build up over time. So, you know, one of the things that I usually tell people, again, if someone's sick and they're going to be in the hospital for a while, they need surgery especially, but you treat their pain like anyone else. So you imagine that there's no addiction, because we all know once you say the magic word addiction, people start acting a lot differently, treating their patient a lot differently. So the idea is going back, pretending like it doesn't exist. So treat their pain like anyone else. You provide surgery like anyone else, and then you deal with their disease of addiction like anyone else with any other disease. So it's kind of a different way of thinking about it, but it really is beneficial. And people appreciate that too, when they realize, hey, you're just treating me like a normal person. So I'm not this horrible person that struggles with opioids. I'm not an addict or a junkie that doesn't deserve treatment. No, treat them like a normal person, treat their pain, get them surgery. And then once they're stable, get them on MAT. Once they're through surgery, once they're through that acute post-op pain, get them on MAT while they're in the hospital. We'll kind of talk about that. So if somebody's in the hospital, and this is something we have to talk to more about our colleagues, and hopefully not so much you all that are here for the talk, but if you're taking a medication as prescribed for opioid use, whatever the MAT is, that is sobriety, right? So we always tell people, don't chastise someone if they're on any medication, because what happens when you do that? So it reinforces stigma, decreases rapport. They're probably not going to be engaged in treatment. They might leave treatment for that matter. So if they're on MAT, they're taking it appropriately, great. Keep it up. You know, of course, we talk about the stigmatizing language, so we're not using clean or dirty any more than someone who's diabetic. So we try to avoid those terms because we're better than that. We know that doesn't really help anything. If somebody is stable on any form of MAT, so they come in the hospital and they're on anything, we restart the medicine. Of course, you know, you want to confirm the dose prior to restarting, and you're going to ensure, okay, this person's in the hospital, let's get them followed up exactly with whoever they were seeing beforehand. The only times you really want to avoid restarting medicine, doesn't matter which one, is if there's a sound medical reason not to restart it. So again, say if somebody's liver is getting fried because of naltrexone maybe, or they're having issues again with their pain is really high and bup isn't cutting it, or God forbid they're on naltrexone, that's really going to interfere with pain treatment, right? So there's got to be a reason, not just because I don't feel like giving somebody their MAT, right? But that happens all the time, clearly. And, you know, just to point out, again, we all here should know this, but maintaining somebody on bup or methadone is always, always, always recommended in pregnancy. So never, ever, ever detox someone. You know, it's kind of remarkable, but up on the DDU, we have some students, medical students that are interested in doing OB work, and one of them just finished their OB rotation, but do you believe it? So the medical students are not trained that at all, even though that is the recommended thing. The even scarier thing that I recently found out was the OB residents. So OB is 4 or 5 years. I always mix it up. I'm not a big OB fan, but OB is a long residency. They do not get a single lecture on addiction treatment in the entirety of their training. So OB doctors to be have no training on addiction, even though it's something you see over and over and over again. That's scary stuff. So things like that we can work on clearly. So it's always recommended you stay on medicine if you're pregnant. So if someone, let's say somebody is in the hospital, if they want to be on naltrexone, again, there's no special licensing. It's not super complicated, but you do have to let people get through that withdrawal process. So 5 to 10 days, I usually say like around 7 is kind of the magic number. But you want to get them off of opioids before you start naltrexone, or you're going to make them really sick. Typically, they say start with the oral form, but the goal is to give the injectable formulation, so Vivitrol, for if you're going to go the naltrexone route, just because the compliance is very poor with the PO or Revia, you might hear that term. Some people will also give like a Narcan challenge prior to giving Vivitrol. That is the thing if you want to try it. So for methadone, if we're going more the methadone route, if they're already prescribed it and you confirm it, that's fine. Methadone by itself can only be prescribed for pain. So if it's prescribed for addiction, of course they need to be through one of these federal OTPs. If it's pain plus addiction, it's kind of more gray, it's okay, but you don't want to be prescribing pain methadone for addiction by itself without any pain. That'll get you into some major trouble doing that. Now, there are certain caveats to that, which we'll talk about briefly, but starting BUP, of course, we need the special DEA waiver, which I'm sure you all have, hence you're on the ECHO for it. And, the exceptions for starting methadone and BUP, for those who are interested, hopefully most of you are aware of this. But say somebody doesn't have their waiver yet, or they're covering in a hospital, or even if you're not a prescriber, not a a PA or an NP or a physician, but this is pretty neat. So the 3-day rule or 72-hour rule. So this is part of the Data Act, but this allows a practitioner who is not separately registered as a narcotic treatment program or certified as a waiver data 2000 physician, so that'd be us, to administer but not prescribe narcotic drugs to a patient for the purpose of relieving acute withdrawal symptoms, while arranging for the patient's referral for treatment of the following conditions. So really the idea with this is that somebody comes in the hospital, you don't have a waiver, but guess what? You can still give them medicine while they're in the hospital for up to 72 hours. So somebody's on the weekend, they say, well, I don't have an X waiver, can't do it. Actually, no, you can based on this. It's kind of a humanitarian thing. Someone's sick, they need treatment. You can do it with Suboxone. You can also give methadone for somebody who's in acute withdrawals, which is pretty neat. So the big thing to note, the caveat is you cannot write them a take-home prescription of methadone or BUP when they're leaving the hospital. But while they're in the hospital for up to 3 days or 72 hours, you can give them either methadone or BUP, which is great. All right, so what are the safeguards if you're using MAT inpatient? This is just good to know for anybody. So if they're already on appropriate MAT, you get them restarted on it, of course. Make sure you're confirming the medication and dose. Methadone is not as forgiving as BUP. There have been cases where just giving twice their home dose has been enough to kill people. So, you got a lot more wiggle room with BUP. So it's okay to kind of rush a little bit more with BUP, but with methadone, sometimes just slow down a little bit, see when they got their last dose, see what dose they're actually on. So just be careful. Again, BUP is more forgiving. Urine drug screens while someone's in the hospital, especially if they're in the hospital for a long time, right? But when you're doing urine drug screens, you know what to look for. You know what your facility actually screens for. For a long time, we didn't even screen for fentanyl, which is kind of scary. Now everything comes back as fentanyl positive, whether it is or not. But also know how to confirm. So what I say is a screen is just a screen, right? So if you don't want to make any rash decisions based on a screen unless somebody tells you, yeah, I use that. But there certainly are the false positives. As I mentioned, fentanyl, we screen for it, and it seems like everybody and their grandma is coming up with fentanyl now. It's just because it's sensitive. It's very sensitive. Specific, it's not very specific. So some more safeguards for those who are in the hospital, clear guidelines for people so they know what to expect while they're in treatment. Drug screens, do them on admission, do them intermittently while they're in the hospital, do them as needed. Searching rooms and belongings as needed if somebody's in the hospital, especially long-term. Being aware of all visitors. Not everybody is interested in recovery, which goes without saying, but you got to imagine if you've been without your drug of choice for a long time and someone brings it to you in the hospital, it's like waving meat in front of a hungry dog, right? Especially if, God forbid, somebody hasn't been on medication the whole time, right? So they don't have any they've just been sitting there in their cravings for weeks, right? Safety precautions, so what do they look like? So sometimes you do need to do video monitoring or a sitter in a room versus the honor system. It just depends on the person. We've had people that relapsed in the hospital, of course. One of the guys I had who was in the hospital for endocarditis, I'll never forget. He was in the hospital for endocarditis treatment. 4 weeks in, I think somebody else in his family had something happened. His dad, who also used, went and relapsed and died in the hospital, another hospital, not his hospital, but a separate hospital. So this guy's in treatment in Ruby, 6 weeks. His dad is dead in another hospital because he relapsed in that other person's room, their bathroom. So nursing and staff education. So again, teaching them to be non-judgmental, lest you're going to get people really upset. Get them in, basically force them into a relapse or into early AMA, which never ends well, pretty much. All right, so if somebody's on MAT and they're leaving the hospital, again, it's a gold standard. Detox plus or minus rehab is not the gold standard, nor is just abstinence. Just say no. Make sure outpatient follow-up is always arranged before someone leaves a hospital, so you don't start them on it and then take them off right before they leave. That would not be good. Ideally with transportation, if that's an issue, which of course it is for a lot of people. And now there are the Medicaid, I forget the name of it. I don't even know if there is a name, but where you can get transportation for folks. We already have Logisticare, but now there are things specifically for opioid use disorder folks, so it's great. Of course, you ensure that they're prescribed enough medication to reach their appointment. So ideally, too, where they take it with them from the hospital. Regardless of MAT, you always make sure that people have naloxone, right, on discharge, regardless of what it is. Make sure everybody has naloxone. So again, somebody, let's say the person that comes into the hospital, they have the endocarditis, they need surgery right away. Imminent surgery plus excessive pain, let's just use regular opioids at first until after the surgery. Once post-op pain has gotten better, we'll stop the opioids, we'll put them in mild withdrawal, mild to moderate withdrawal, then we'll start BUP, right? Get the BUP to a goal dose, again, 8 to 16 milligrams, maybe a little more. We can provide extra medication as needed for breakthrough pain. Again, kind of the pain duration of action is a lot shorter than really the duration to suppress opioid withdrawal and craving, so you have to dose it more often if you're using it for pain. You give them BUP throughout the time they're in the hospital, which for a lot of people is 6 weeks. And while they're in the hospital, let's get them group therapy. Let's get a peer recovery coach. Let's get them all up there. That's kind of the ideal situation. And we set them up with the outpatient clinic with one of you all immediately after discharge. And we only give them enough medicine to reach that visit. And we always, again, make sure that we give them Narcan script. All right. So how do we do it in the emergency department? This is the horizon. This is where we're going. We're working on it. It's not perfect yet. There's a lot of things to work out, but we're getting there. So the acute opioid overdose. So someone comes in, it's the middle of the night. It's always the middle of the night when people overdose from opioids. So they come in, they've got hit with Narcan multiple times. So what do? So historically, if someone overdosed and they didn't want treatment, they would just allow them to leave AMA, no further intervention. Don't use again. Good luck to you, sir. Take care. We try to avoid that now, of course. It's unfortunately still some emergency departments that this is their gold standard, so to speak. So we could offer them inpatient detox. So you had your overdose. Let's detox you and we'll see what happens. Yeah, they'll probably leave AMA and go use again. Sometimes we can get them in. Sometimes they have to wait 12, 16, 24 hours to get in the hospital or go to one of these small detox facilities if your insurance will pay for it. We could give them a referral form for local MAT, MOUD clinic. Great. That could work. It's an option, certainly not a guarantee of success, right? Because whatever time is in between there, somebody is overdosed and received Narcan. The first thing on their mind is not feeling terrible again. They want to go and use immediately. So the goal is to give them MAT while they're in the ED with an outpatient referral. Okay, so they get the medicine, they get the outpatient referral, not just the referral, they get a date, plus or minus inpatient treatment if it's feasible or available, right? So you dose them, you treat them. Maybe you do need to go to treatment. Maybe we can just send you to outpatient in 2 days. Probably the best option. This will become the standard of care at some point. In some places it already is, but this will be the standard of care, is to dose people that have survived an opioid overdose. So what are the benefits of starting people on BUP in the emergency department? So people follow up, surprise, surprise. They stay in treatment. They have less days of illicit opioid use, and they have less psychiatric admissions. So all good things, less deaths too. We'll talk about that again. But the goals, as we always circle back to, but let's reduce mortality and morbidity and mortality, and we'll increase the quality of their life, right? So we're keeping them alive. Probably mortality twice is worth saying just because it's so true, but keep them alive, get their quality of life better. Again, the 72-hour rule, which we already mentioned for inpatient, but this is also true for the ED. So EDs can prescribe people medication even if the ED provider does not have the waiver for BUP, or it's methadone, which you don't really have a waiver for methadone, but this is feasible in the ED as well. So keep that in mind. So what happens if an overdose patient receives treatment with MAT? So someone survives an overdose and they actually do get medicine in the ED. So this was a study done in Massachusetts back 2012 to 2014, but about 20,000 people survived a non-fatal opioid overdose. That's a lot of people. So only of those, only about 3 out of 10 got any kind of MAT. So the majority of people, no medications, no nothing. They survived the overdose, see you later. Methadone was about 11%, over 2,000 people, and they received it for about 5 months. BUP was 3,000 people for about 4 months, and naltrexone, about 1,000 people for 1 month. For those who don't know, the average number of Vivitrol doses that people receive is 1. So they get it one time and they never get it again. So hence why naltrexone has a lot less follow-up. So all-cause mortality of folks that died at 12 months was, this is a good study, it really is, but about 5 people died per 100 person years. So that's not per 100 people, but 100 person years. So a lot of people died. Now with MAT, especially so methadone and BUP, you saw a reduction in mortality. So 53% with methadone, you know, they're being seen daily, 37% reduction with BUP. So, you know, different clinics, different policies, who knows how robust the program is they're going to, and then really negligible for naltrexone, partially because there is not as many people, but again, only 1 month of treatment, that's not really treatment. All right, so a little bit in the demystifying MAT in the ED. The patient would like to be placed on MAT and is at no risk for precipitating withdrawal. So somebody say they come in 3 days after their last use. There's no reason not to just dose the patient. And I say cumulative overdose because you got to be careful with methadone because it's a full agonist, right? If somebody still has heroin floating around, but if they're sick, because they're already in withdrawal, dose the patient. Give them medicine in the ED. If you start them on BUP, start them anywhere between 2 and 8 milligrams. Again, the goal is to suppress withdrawals and cravings, and also not get them sedated, which is fairly hard to do, get them sedated with BUP. For methadone, you know, you have to be a little more adventurous to do this, but it can be done. So methadone, you can give them a low dose of methadone. You can give them more. Usually they say the max in day 1 is 40 milligrams. For those who aren't too familiar with methadone, you know, typically like a pain dose of methadone. So what most people are prescribed is like 10 3 times a day, but for addiction, it's usually anywhere between 60 and 120 milligrams, sometimes more, sometimes less. So start on the lower end and work your way up because it is a full agonist. There is overdose potential with it, so you got to be careful. So interestingly, I'm not really talking about it here, but there are these protocols being developed to give really high doses of BUP after an overdose. So say somebody overdoses, they still have some opioids floating around the system, but you knock them all off with Narcan. You can give them BUP, but not just, 2 milligrams of BUP. So the idea is, and what we'll probably be doing at some point in the near future, is give them, say, 8 milligrams. Here's an 8 milligram film. You just had an overdose. Here's 8 milligrams. And then we give maybe another 8. So somebody's gotten 16 milligrams within 10 hours of their overdose. And what are you doing when you really fundamentally think about it? So you're replacing the full agonist that almost killed them, with a partial agonist that is going to prevent a certain level of oversedation, respiratory depression, right? The concern that people get if you give bup too soon is, again, you put them into kind of a precipitated withdrawal, but they're already in a withdrawal from an overdose. So it's a little, it's not quite ready for prime time in most places, but it's something worth looking at. Here's somebody talking. Okay. All right, so what would be the ED plan of care for someone who did just survive an overdose? Just kind of an idea to, for you to work on. But one is, if somebody has been in active withdrawal from getting naloxone multiple times, so they're already sick, so you could start them on bup, and you just keep giving it to them until the withdrawals stop. So you get those withdrawals suppressed. You let them know, hey, I know you just survived this. I know you want to use right now. Let's see if we can get you feeling better quickly. And guess what? Even if they leave AMA, they've got bup in their system, so it's going to protect them somewhat from an overdose. So you get them, you monitor them for a while and make sure that they're stable. You discharge home with family if you can't get them into a detox program or inpatient treatment. You give them enough medicine with a prescription with enough medicine to reach that appointment that you've already made for them, and the appointment has to be very soon after it. You be sure that the family that you're discharging them with has Narcan in hand, right? What I always try to do is, encourage people. Recovery is possible with the right tools and support. The reality is, a lot of folks that we see, they've never been offered treatments, or it's been not the best treatment, to put it mildly. So people do get better. We tend to focus on our failures, but a lot of people actually do recover from opioid use and go on to live normal lives. All right, so in summary, can be successfully started or continued whether somebody's outpatient, inpatient, and in the emergency department. It's not all that complicated once you know how to and once you've done it a few times. If someone does not have a waiver, there is that 72-hour rule that you can use as inpatient or in the ED, right? You can't do it as an outpatient, can't prescribe it. Really starting a patient on appropriate MAT is really, truly one of the most effective interventions we have in combating the opioid crisis. What I would say, especially, just to consider, again, these other settings, especially inpatient, but outpatient, and looking at ways that we can kind of incorporate some of what we do from an outpatient setting, into the inpatient, but also into the emergency department. All right. So do we have any questions, anyone?
Thank you so much, Dr. Husted. That was awesome. Lots of great information in there. So any questions or even comments for Dr. Husted? We've got a thank you in the chat for you. And feel free to unmute as well, everyone.
Dr. Husted, this is David Baltiera out here in Eastern Panhandle. How much do you know about the 1-week buprenorphine injection? I know that there's a phase 3 trial going on that one of our local hospitals is. Anything we should be aware of with that following up?
Absolutely, absolutely. Actually, so the FDA, it's going to be called Brixadi. Okay, it's been actually approved in Europe for years. So this is not something new. For those who know about Sublocade, so this Brixadi stuff can be stored at room temperature. There is the 1-week shot and a 1 month. Sublocade only has a 1 month. We're actually about to do a huge research study using Brixadi. It should be approved, at my guess, probably in the next couple months. So it should be ready soon. It'll probably bring down the cost of Sublocade, but I think it's going to be a real game changer for all of us. Okay. So, because right now, again, the issue with Sublocade is you give it a month from then, the person might show up, they might not. With this stuff, 1 week at a time, probably early on, it fits much more into kind of a COAT model. So I'm really looking forward to getting a chance to use it. And I'm sure I'll report more in the next couple months because I'm about to get the chance to actually.
Yeah. And how would that affect the 72-hour rule? Because you're really giving, a week's worth. So I guess it's, maybe I don't want to ask that question.
I don't want to either.
Okay.
Right? That's a good point. Yeah, it's called Buvidal in Europe, if you want to look it up, by the way.
Yeah.
CAM 2038. It's Braeburn from Sweden. Go Sweden. I'm quarter Swedish. Yeah, Buvidal, be called Brixadi, for those who are interested in looking it up. So, the smaller shot, stored at room temperature, weekly and monthly form. So overall better. And apparently Sublocade is kind of painful to put into. I haven't got a chance to mess with it, but this stuff
I think it's the oil or something, you know, how it lasts that long and people get nodules, and, you know, I haven't had a lot of experience, but that's what patients have told me.
Yeah.
And just to clarify on once a patient's inpatient, you can continue their buprenorphine or methadone for as long as they're inpatient. That's separate than the 72-hour rule. That's just for initiating people, correct?
Yeah, initiating, or if you don't have your waiver, you know, you forget to get your SAMHSA renewed or whatever. I don't think you have to renew it. My DEA almost lapsed. Thankfully, I got it in time. But yeah, that's basically something you can tell your colleagues too if somebody's on, and you know, I'd love to start it, but I can't. Well, yes, you can. Right. So yeah, it can, especially in the EDs.
Yeah, because one of our EDs, that's what they're doing. They have people come in every day. They administer it to them up to 3 days. And I think it's based on that, which actually, it's not the best, but it actually works. I think it gives it, you know, the weekend to get people hooked up and stuff.
Yeah,
so.
yeah, that's great as long as they're doing it. So what scares me is when you have hospitals that don't even have it on formulary, you know, which is, it just, I mean, can you imagine if I said I didn't have aspirin on formulary? It's just.
Yeah. If anybody wants, we're a smaller critical access hospital, and I know some of the places that work there, we developed a policy for it that, you know, people, I'm glad to send to people if they want. WVU is a little different, you know, but we're a 25-bed hospital. And so, yeah, having it on formulary is key, you know.
And Dr. Voltaire, if there's anything you'd like me to share with the group, just shoot me an email. I can send it out to everyone. And Mark, I saw you chatted in a question. You could probably articulate it better than I can, but do you want to ask it for the group?
Sure. Hopefully, Dr. Houston, you get to see it early there. It was two things really, just, you know, the pharmacy thinking side of it all. It would probably be valuable for everybody going over when you're talking about in the ER, a patient utilizing MAT comes in, pain, car accident, whatnot, broken leg, this, that, and of course using, gosh forbid, opioids, prescription opioids for pain, of course, but what kind of doses are we talking? You obviously
for what like
for the pain, while that's being treated.
Okay, so you know, with bup, usually, you know, given like additional 2s at a time, if you can live with bup, if you can do bup, right? You know, one of the ideas that they have had to do if somebody's, again, they're on Vivitrol, God forbid, you know, fentanyl, like actual fentanyl with Narcan handy. You know, don't forget about some of the NSAIDs, right? So you give somebody a Toradol shot, right? You don't have to worry about the blockade. You know, there are certain times that they'll use gabapentin. I think we've talked about that, mixed with buprenorphine. You know, not something you really recommend as an outpatient, an option. You know, sometimes they even do full opioids with bup. If somebody's really sick, you just, you know, and they want to stay on the medicine. It's not something we traditionally do, but learning the more tricks you have up your sleeve, the better. This kind of stuff. With methadone, just be really, really careful. The nature of methadone is scary.
Yeah, I think everybody always could appreciate that extra little bit, like that. I knew you had the info. The other thing isn't necessarily a question for you, but it's a kind of common question just because it's a conundrum that's out there. On our society, especially even on the law side, the whatever side, there's a lot of concentration on enabling more prescribing of MAT bup. Sure, we could all agree with that. One of the conundrums, though, is that's not the whole supply chain of prescriptions in our country. Yeah. So you could prescribe all you want, but then the patient goes to the pharmacy, and my peeps are like, yeah, we can't. We're limited. There's no supply because the DEA is barking down everyone's throats. And that's why a lot of West Virginians end up going to Pennsylvania and vice versa, and this and that, and it's a fiasco in many accords. And then pharmacies could look bad because they got people coming from out of the state or out of the city, and then you know, everybody's yapping about that then. So in the idea of like, okay, in the ER, are there any, do you foresee any negative things, or are there any efforts in a positive way to say, okay, here's first dose, here's first 2 doses, whatever the case may be for the duration, then what? Because there's, I don't believe in this Zoom call, but in other ones I've been in, there's this natural thing like, oh, it's prescribed, we're good, you can get anywhere, it's lisinopril. Or you know,
No, it's good for, I would say, for anybody that's wanting to do this, just make sure you check with pharmacies in your area. I'm sure everybody has, but knowing which pharmacies carry it and which ones don't. And especially too, we all know that in January, we're gonna have to e-script all controlled substances. We can't just hand them the paper script anymore. So all the more reason we need to know who carries it, who has the capacity to fill it, and who doesn't. So.
I know, like in our ERs, we've started doing the Suboxones from there. And what we have someone down there who would actually set the patient up with different outpatient clinics appointments within that week. So that's what's been helpful for us, because otherwise you do have a, you know, kind of like a disjointed service.
Yeah. If you have a hospital discharge pharmacy, that's the ideal, at least for the first doses, of course. People leaving the hospital with the medication in hand, not with a prescription in hand.
So we are at 5:01 p.m., so it's the end of the session, but for those of you who can hang on, that would be excellent. We did get one last question. If Dr. Hughes said you're up for answering it a little past 5. So Bree Shepherd just chatted and asking, so for those who, which Sublocade may be an option that the patient might prefer, for example, in rural areas where it may be a better option due to limited transportation. What recommendations do you have to keep patients engaged, to help keep them engaged in the treatment program?
A good question. I wish I had all the answers. I think, you know, even if it's going to be once a month, especially early on, if you can get them seen like once every other week, or have people maybe contact them in the interim. And, you know, I think that's a ball that often gets dropped, you know, how are you doing in between visits? We're going to see you next Tuesday, you know, that kind of thing. But it is very tricky. I mean, that's really the issue with Vivitrol, is you give it and then they're in the wild for a month. You know, maybe this is a place where contingency management would play a role, you know, having them come in and get a reward between visits, not necessarily the medicine, but some kind of something else with value. I could see that being helpful. You know, the app too. So like the chess app, things like that. There are other things that we can take advantage of that we didn't have before. But I think, you know, once all is said and done, like we talked about with the new injectable, I think Sublocade is an option, but the other stuff is really going to be a game changer, where it's once a week at first. You do that maybe for a couple months, and then you transition to the monthly form of the injection. But trying to avoid the weekly or the monthly right at the get-go. So.
And the Sublocade it takes a while to hit steady state. So at first, you might actually have the first couple months, some people going into withdrawal before their next injection is due. So sometimes what we use to say, hey, make sure you show up, because if you go into withdrawal, you'll need extra Suboxone to take you over until your next shot. So that's been helpful for us.
Thank you, Dr. Bell. And thank you, Dr. Morrison, for chatting in too. He says, thanks for the great presentation and awesome questions. But, all right, thank you so much, everyone. This has been such a great session. Just one announcement before we part ways. Our next session will be on November 23rd, and Dr. Hirschler will be discussing dosing Suboxone. So keep an eye out for that reminder, and we'll see you guys next time. Thank you.
Well.